First of all, to those of you who have joined us, thank you for being a part of our DBSA Leadership Summit, its second year. This last year, the summit was devoted to our chapters around the country, and this year we have tried to greatly expand it and have it open to the general public, and our hope is that it continues to grow each year after year. Welcome to, our attendees. My name is Douglas Holst. I am the Peer Specialist Workforce Development Program Manager for the Depression and Bipolar Support Alliance. It is my privilege and it is my pleasure to be here with you today. It is absolutely a dream come true for me to work for the Depression and Bipolar Support Alliance. And it is an honor to be with everybody, especially the clinicians that we have with us today. Today's topic, this afternoon's topic, is about the effectiveness of peer specialists in mental health recovery, a clinical perspective. And I was sharing with our clinicians a moment ago before we formally began, and I want to share with everybody now the inspiration for that, what inspired that. And very quickly, I'm a person that has three big chapters to his wellness story. The first was coming to terms with my sexuality. The second was a major depressive disorder moment in my early 20s that led to a very extreme generalized anxiety disorder throughout my 20s. And the third was those two things leading into a substance use disorder issue in my 30s. And I'm happy to say I've been sober from alcohol for 7 years. Mental health and wellness is one of my greatest passions, and it's an absolute privilege to be a part of DBSA, to work in this arena, an arena of mental health and wellness that I never dreamed I could work in without becoming a therapist or more. So the inspiration for this session was when I was very accidentally introduced to the world of peer support, which was seeing a flyer up at where I was getting formal treatment for alcohol use disorder. I took a peer specialist course just for fun and just to deepen my own wellness journey, my own sobriety, my strength, my resiliency. I didn't have any idea of what the world of peer support was, peer support specialists, what they do. And I certainly wasn't engaging with clinicians. Even in my very wonderful formalized treatment program I had, my clinical support staff wasn't talking to me about the world of peer specialists and peer support. When I got a little bit deeper into that community, I often would hear individuals talk about and say very generalized statements such as, I don't think clinicians know about peer specialists, or I don't think clinicians value the work of peer specialists, and isn't the whole point of peer specialist work that it is not clinical in nature? And that is true, that the work of a peer specialist is not clinical, but it is very much connected to the work of the clinical. And over the past 5 years, I have learned that more and more and more, almost on a daily basis. So audience, the three clinicians that I'm going to show you just in a minute, because I'm not sure you can see their faces right now, I'll show you their pictures. We have Dr. Megan Mayberry, Dr. Karen Rentis, and Dr. Charles Reynolds. In my time here at DBSA, as they know, I'm never going to stop telling them, these three clinicians have become my rock stars. I look to them for information, for guidance, for support, and their wisdom touches me almost on a daily basis. Before I let them introduce themselves to all of you, I want to just quickly share, Dr. Mayberry and I met. DBSA did a congressional briefing in late February of 2020, about 3 weeks prior to the shutdown from the global pandemic. And Dr. Mayberry was a part of that trip to DC. So that was how I got to meet you, Dr. Mayberry. Dr. Rentis was also part of that experience, and I believe how the two of you met. But I had met Dr. Rentis earlier in that my beginning time at DBSA was about our senior strength program. The senior strength program, in a nutshell, is getting clinical referrals to have older individuals suffering from a high marker on their PHQ-9 depression screener to then connect with a peer specialist. And Dr. Rentis was our site champion and just champion in general for that program, which is slowly winding down out in Los Angeles. My introduction to Dr. Reynolds was his support we had for online support groups last summer when the pandemic hit. And we had a grant to do a similar project as we had done with Dr. Rentis. And suddenly the grant flipped to offer support for online support groups, and Dr. Reynolds was a key contributor there. Dr. Reynolds, however, had already been one of the support people for the senior strength program out in Los Angeles, and that he had helped prepare clinicians out in Los Angeles to understand what was coming. So thank you all so much for all of that work. Thank you for being here. Dr. Mayberry, could I invite you to introduce yourself?
Yes, hi. Thank you so much, everyone, for being here, and I'm really honored to be here myself. So I am a psychologist who works for the Hines VA in the Chicagoland area. I supervise a team of peer support specialists who are integrated all over our hospital in a bunch of different clinics, which I'll talk about a little bit later, and really work to helping peer supports integrate into those clinic areas and promoting the discipline of peer support in general within the VA. And then another part of my job is focusing on implementing recovery-oriented care throughout the VA and different mental health programming. And then clinically, I specialize in working with veterans who are struggling with suicide. So that is where most of my clinical work is, and developed a intensive outpatient program in the VA to help connect with people who are struggling with suicide in a recovery-oriented way to achieve the outcomes that we wanted. So I am gracious and lucky enough to be able to also do that clinical work within the realm of managing the peer specialists that we have here. So thank you. I appreciate being here.
Thank you, Dr. Mayberry. Dr. Rentis.
So as Dr. Mayberry mentioned, it's an absolute honor for me to be part of this conversation today. So I'm a clinical psychologist. I work for Providence Health System. I'm based at, as Douglas mentioned, in Los Angeles area. I'm based at one of our medical groups, FACE Medical Group. So as part of my role, I oversee and support behavioral health integration with primary care. So we have a group of behavioral health licensed clinicians, including therapists and psychiatrists, who are supporting our patients that are connected also to our primary care physicians. So we wanted to make sure that all patients that come to our doors are able to connect with behavioral health if they do present with behavioral health needs. So in regards to our work with peers, as Douglas mentioned, we had a project that we are winding down where our senior patients with symptoms of depression are identified. They come to their appointments with the psychiatrist and or a behavioral health licensed clinician. But they're also refer for them to get more support outside of the clinic setting. So we have peer support specialists supporting patients in the community. And we have amazing experience in connecting all the dots so we can support better the same individual. So again, I'm a true believer of peer support specialists, and I'm hoping to share a little bit of that throughout this conversation.
Thank you, Dr. Rentas. And Dr. Reynolds.
Thanks, Douglas, for the privilege of being with you and Karen and Megan today. I'm a geriatric psychiatrist, professor emeritus at the University of Pittsburgh School of Medicine. Much of my work has dealt with the prevention and treatment of depression in older adults. I've also done a good deal of work with grief disorders and sleep disorders. My work with peer support specialists occurred as a result of an invitation from Phyllis Foxworth at DBSA, and it was from Douglas and colleagues that I learned a great deal about the peer support program of DBSA. I came to it with a background of experience with the use of lay counselors, lay health counselors, and also with community health workers. And I've come to see, Douglas, I've come to see peer support specialists as part of a very important continuum in the nation's mental health workforce, of which lay health counselors, community health workers are also a very important part. It was my privilege to work with you, Douglas, and with several other peer support specialists over a 6 to 8 month period last year during the pandemic. And I came very much to appreciate what a lifeline peer support specialists are to those living with mental disorders, and how important their own experience with mental disorders is in terms of helping them to be present, to be there, to be truly helpful to other persons. So this is an exciting time, and I want very much to offer my thanks and congratulations to DBSA for this program, and my hope that it will continue.
Thank you, Dr. Reynolds. Thank you all. It's always good to hear. I just like hearing about your introductions, even though I know you. Members of our audience, what I would ask for you to do is we have a very loose agenda today, very informal, and I have a series of questions that I'm going to ask each one of our clinicians. As you listen to the questions, as you listen to their responses, I invite you wholeheartedly, please enter any question that you would like into the chat. And at the end of our session, we will go through those questions. So again, as you listen to the questions, as you listen to our clinicians respond, please let that inspire you to ask questions or new questions that may come to mind. And certainly in the chat, if you want to put in questions that you've had for a long time that you've been waiting to ask, please do so throughout the experience, and we'll look at those toward the end. I want to also just remind those in our audience that certainly I feel that having our panelists present today is just a really rare opportunity. So please take advantage of the opportunity and ask clinicians what they think. Certainly the doctors will give you their honest viewpoint on whatever it may be. So the first question that I asked our three clinicians when I reached out to them earlier was honestly a question that I myself was just extremely curious about. And that was, at what point in their schooling or education process or in their career did they first learn about this thing called peer support? I am very interested in and fascinated by their answers. So I'm just going to start with how I see you on my screen, and it happens to be, I think it's alphabetical. Dr. Mayberry, when did you learn about peer support?
Yeah, so I actually, DBSA was my first introduction to peer support, actually. I went to graduate school in University of Illinois, Champaign. And, to be honest, I don't remember how I fell upon this peer support group at DBSA, but somehow I learned about it. And they were wonderful humans. They invited me. I showed up at their group. Sometimes I would give them, mental health materials or resources, but mostly I just hung out and listened and kind of watched the process of peer support happen. So I did that for about a summer in my grad school with there was no agenda. I wasn't researching anything. I was just like, this is a cool group of people who have this different way of figuring out mental health. Cool, right? So then I graduate. I get a job at a university, local university around here. I start doing clinical work. And frankly, I didn't think about how that experience, peer support, intersected with my clinical work very much at all. Then insert getting a job at the VA a little over 10 years ago. And the VA really lays the groundwork for integrating peer support in clinical work, that they have done a lot of work in kind of how to use this lived experience with clinical work. So I'll give you an example. Right in the beginning of working in the VA, I found that I was seeing kind of back-to-back folks coming in with combat exposure. They were just returning from Afghanistan at the time, young vets, and every single one of them was saying, man, I feel crazy, and this is what's happening. And I'd go session after session after session just listening to people feel so disconnected and I'm really struggling with their mental health. And I had this privilege of being able to have a narrative of, other people are struggling with this too. So my clinical head says, make a group, right? So I design a group for these folks, pulling them all together, figuring out how to think about transitioning into civilian life, pulling all the literature, research, all of that. The group goes okay. There's some engagement challenges or some participation issues. So what I ended up doing is asking a peer support to come and join me, which was just awesome. It was incredible. This peer support did have combat experience, and she was able to figure out how to take. So I'm a clinician, and I know all the science and all the tools and all the stuff of how to help people recover from PTSD and how to do this. And she was able to bridge that with these folks that were just coming, who were so raw and so isolated and mistrustful and really struggling. And she was able to bridge those things to make this really incredible, meaningful program. So I think it wasn't until that experience that I got it, that I kind of saw how peers can use their experience to highlight, hope and empowerment and what that process looks like. So that was, over 10 years ago in the VA, and I've been a supporter of peer support since.
Thank you, Dr. Mayberry. Dr. Rentis, what was the moment that you intersected with peer support?
So very similar to Dr. Mayberry's sharing. So I did my predoctoral internship as I was completing my PhD in clinical psychology. So I did my internship, which is that last clinical year with a lot of, it's very heavy on clinical experience at Rutgers University Behavioral Healthcare. And as part of that program, I was assigned, or I chose to participate with one of the programs working with patients with severe mental illness. So patients who had schizophrenia or bipolar disorder or depression, but they were really, their functioning was impaired. And that program, to be quite honest, I don't recall what was the name that we had for that role. Was it peer support specialist or patient advocate or patient navigator? I don't recall the name that we had for that role, but I do recall that the peers that we had as part of the program, they were part of our clinical team. So they would join in clinical discussions among the care team, which included psychiatrists, RN, the licensed clinicians. So they were part of the team, and they would actively participate in clinical conversations. They would also they were the ones that were constantly on the phones. They were constantly, going out to the community to connect with the patients. They would also share their insights with us, the clinicians, around how to connect better with patients. So I had patients myself there where they were not coming to treatment, or even if they were coming, there was some kind of disconnect. And the peers did a great job translating some of that science that I knew and I was trying to communicate, but they would reinforce the same messages with my patients in a language that it was so simple, grounded, that there were actually, I will start seeing changes in our patients. I really enjoy working with peers because there was somehow, it made me feel more connected to my patients, and my patients were responding to those interventions. So going back to what you mentioned earlier, Douglas, even though the peers were not doing therapy per se, their interactions with our mutual patients were therapeutic. And I could see it in their work with our patients, where they were constantly, doing the extra to work with patients, connect them to treatment, and translating, the treatment that we were doing. And also just trying to decide when was the right timing for them to share their own journey, not for them to heal themselves, but to support the patient better. Great experience. So that was about a little bit more than 10 years as part of my internship.
Thank you, Dr. Rentis.
Sure.
And finally, Dr. Reynolds, when was the moment that you learned of peer support specialists and the work?
Yeah, one comment I'd like to offer, Douglas, is how much I appreciate what Karen and Megan have said about the importance of peer support specialists providing a bridge or a connection between clients, between patients, and the clinical team. This is something that I've seen in a number of different contexts in my work as a research psychiatrist, including work with lay counselors in primary care settings who delivered problem-solving therapy in a project supported by the National Institute of Mental Health, focusing on depression prevention in at-risk older adults. It's also of something that I saw in a very lively way in my work in Pittsburgh, in the African American community in Pittsburgh, where we engaged community health workers to interface with older African American adults to encourage them to seek out and to connect with clinical teams for assessment and treatment of depression. It was against that background that I came to DBSA on the kind invitation of Phyllis Foxworth, and then met you and the team, where again, I appreciated with considerable depth the bridging and connecting function that Karen and Megan have described so well.
There's the phrase that I think I've learned from the three of you, and including you mentioned Phyllis, who is our vice president of advocacy and my boss and our team leader, the continuum of care, and how peers are a vital part of the continuum of care. I'm going to move to our next question, because I now have an additional questions that I think I want to ask too before we run out of time. But you sort of touched on it, the three of you, already, in terms of when you were first exposed. Well, let me take one step back. Is it true to say that none of you were exposed to the work of a peer specialist during your education, or am I wrong about that? Dr. Rentis, did you say it was, did you learn of peer support before or after you finished your education?
I would say in between, because as part of, bachelor's, master's, and getting my doctorate at grad school, I did not hear about peer support specialists, but the internship, which is the very last year of grad school before getting my doctorate degree, that's when I learned about it. So it wasn't like an academic setting, but it was like a true clinical setting. So it was like somewhere in between, the academic experience and the clinical work.
Did Megan or Dr. Reynolds, do either one of you have a comment on that too? Did you, was it before or after your education that you were exposed? I think Dr. Reynolds, you said it was recently, so I'm assuming that was later, but for you, Dr. Mayberry, was it before or after as well?
Yeah, I wouldn't say that I was exposed to peer support in an academic context, right? It wasn't, this is a tool that can help your clinical work and thinking about that. I don't remember how I fell into that group in DBSA. I really don't. But I remember the coffee shop we met at. So it was during grad school. So somehow, I've always been a big proponent of connecting with the community and doing that. So I would imagine that's been in my fabric for a little while, and I kind of sought out how that works. So it was during my graduate school training, but it wasn't part of the academic kind of coursework or rigor with that.
My experience was very similar, Megan and Karen, to you guys. I think, Douglas, also that the peer support movement, if I could call it that, really represents an important shift in the culture of mental health practice, diagnosis and treatment and prevention, which puts a much, much greater weight on the importance of lived experience, on the importance of listening to patient and client voices. And for me, I think that's been a tremendously positive evolution in the culture of mental health services delivery.
Thank you, Dr. Reynolds. This is, do any of you think that, I'm trying to figure out how to word this, young students now going down similar pathways that you have gone down, are they likely to be exposed in a formal or academic setting to peer support, or do you think there's still a lot more work to be done there?
I think it's much more likely now, Douglas, that they would be exposed to a culture that nourishes the peer support program. At the same time, I think that the governing bodies that oversee the content and structure, for example, of psychiatry residency programs would do well to take greater cognizance of programs like that of DBSA.
Thank you. Dr. Mayberry or Dr. Rennes?
Yes, I agree. I think that there is definitely a good momentum that allows for more exposure and for more formal training. I would say that, and this is something that started prior to COVID, but COVID just brought to the surface the big mental health gap that we have in our country. And I'm not sure if it's I guess it's one of the benefits that now the awareness is there. So there is major increase in people reaching out for help, but even for those that have been through the journey, there is a bigger acceptance to share that, coming from a experiential perspective, and share that. So I think that there is definitely a very nice shift in as a result of COVID in regards to mental health and just people being honest and being able to kind of like work with stigma. So I think that hopefully even like students that are right now in med school are getting more exposure to this model, that I think it's it should not be the backup plan. I think they are, peer support specialists should be part of a team, not as a option B, but as part of, option number one, the original plan. So.
Thank you.
Sure.
Dr. Mayberry, did you have any thoughts?
Yeah, I would briefly add, I do think that folks that are getting at least training in psychology are introduced to the recovery model, and part of the recovery model includes peer support. So I
Mm,
think the idea of that as a discipline and that of that as an idea exists, right? So I've done trainings with students for, over the years, and I think that the recovery model is being folded into training more every year almost. So I think they get that. I think that the maybe the carve out or the work to be done is really figuring out how, young professionals or any professionals, I guess, but how training programs, how we can best utilize the peer support as a clinical tool, or like a professional within this continuum of care. How do we best use peer supports? And I think that piece is, maybe it's kind of like they exist and they're here. So I think integration still has room for exploration and help with that. But I do think the term peer specialist is more well known now than it ever has been.
thank you.
Megan, I'd like to really signal my agreement with what you just said about the importance of continued efforts to integrate peer support specialists within broader systems or continua of mental health services. And Karen, I wanted to thank you for reminding us about the importance of the issue of stigma and how I think peer support specialists have been an important part of our workforce to combat stigma.
Thank you all. I'm looking at our time, and I want to make sure that I allow time for our audience to engage. Before I do that, in just a moment, and thank you, audience, for the questions you've provided. A question that I was going to save for later, but I feel like it's relevant now. For the three of you as clinicians, because you've touched it, in touching upon when you were exposed to the value of peer support, I think that also touches upon how that's played out, recently in your career. You can see it and you can identify it and say it's valuable, because that was another thing I was going to touch on in a moment. But instead, I want to ask you, when you encounter clinicians that are unaware of peer support, or are aware of it but don't see the value, or don't understand the value, or don't believe in the value, or if I may be very, very frank, if a client or if a colleague would say to you, well, how is this person's lived experience in a short training compared to the 8, 10, 12 years of education we have and then work experience? How do you respond to that as clinicians who value peer support?
I think one point that I'd like to emphasize there, Douglas, is that peer support specialists help to reduce the terrible burden of isolation that is born of living with a mental disorder, because these are persons who know that isolation themselves, and they're in a great position, as Karen and Megan have already emphasized, to help bridge the gap between the person living with mental illness and the clinical team. That's a really, really important gap to try to bridge in the formation of a good alliance to help someone with the process of recovery. I think that's the theme I would hit hard with such a colleague. Maybe Megan or Karen, you have additional thoughts about that.
Yeah, I was going to share that I am not necessarily actively advocating or trying to convince my peers, professional peers, around how beneficial it is to have peer support specialists support the same patients that we are treating. So I don't think that I'm actively, raising that as something in my daily work. But I could share that within my direct team. I think that, just by the fact when we had meetings where peers are part of those meetings, and we are taking a deep dive into a specific patients, that's when they get to see, oh, I see how this is helping our patients. So I don't think that there is a particular message that I need to deliver, but just show and demonstrate as we start collaborating with peers. So I think it's a win-win dynamic of, you know, bringing the peers to the same table where the other professionals are, and just have conversations, and we all learn from each other. It takes a village. So I think that also the peers get to learn about how we work with patients in a way that when they connect with our patients, they have a good sense of what areas are to be addressed by the licensed behavioral health professional versus what areas it's for them to continue supporting. So I think, again, I don't have any particular cliche message to advocate for the value of the peers, but I think the work speaks for itself, and that's been my experience with my team.
Thank you.
Sure.
Yeah, Karen, I really love that. I think really understanding for some of those folks that don't, have the same appreciation for peer supports or what that looks like. I think it's really important that peers aren't treating patients, right? They are providing an example of how recovery looks, right? They're showing people how to take the reins for their own recovery process and what that looks like. They're an example of that, right? So they're not even in the business of treatment, right? That's not what they're there for. So I think really trying to highlight that, right? This isn't a conflict. This isn't like you're going to take my job in a couple of years. We are all working together to try to develop this treatment team that really works. And you can't show me a clinician that hasn't gotten stuck with a veteran or a client or a patient with engagement, or they've plateaued in treatment and they're just not going anywhere anymore, or they finished treatment and it went well and then they're back in your office in 6 months. What happened? Each one of those steps, a peer support has a really important role for. So I think highlighting that, and as folks get stuck, having enough people know about peer support and what they can do to insert that into the treatment plan, or kind of be thinking about, gee, I wonder if a peer support might be helpful here, and here's how. Kind of advocating in that way, or thinking about treatment in that way, I think is really really important.
The power of
Thank-
example, Megan.
Yeah.
Thank you, all of you. I'm gonna jump to some of our questions. Just looking at our time, we only have about 10 minutes more. Let me see here. I'm going to go backwards. Carl asks, do you see clinical research in the area of peer support? And have you been involved and I'm just going to rephrase it. Have you been involved in any research in any way in better understanding the field?
Douglas and colleague in the audience, the research that I've been involved with has been NIMH sponsored, and it has dealt primarily with other types of colleagues within the spectrum we've been talking about, particularly the use of lay counselors to deliver depression-specific structured psychotherapy to people at risk for living with depression, and also the use of community health workers to reach out and engage, particularly older adults who are members of racial or ethnic minority groups, to encourage them to engage in treatment. And both of these approaches have been shown by NIMH-sponsored research to be highly effective. I'm working now with the Senior Strength Program, of which Karen Rentis is a director at FACey in LA, and we're going to be analyzing the data coming out of that program a bit later this year, and I'll be serving as a DBSA consultant to help with that data analysis.
Thank you.
Yeah, thank you so much for all your work with this. And Carl, love the question. Super important to, what the heck are we doing? And is this actually helpful? And I do want to remind folks that as we stand right now as a field, peer support is an empirically based process, right? We know that peer support is helpful for reducing inpatient stay and connection and increasing quality of life measures. There is a growing body of research that shows that peer support is a helpful intervention. So I just want to say I appreciate that question. For me, all of my data collection is all in the spirit of program evaluation. So as opposed to being on the side of running clinical trials and that piece, I collect data from my peers to make sure that that they're doing their job and what's happening is actually working and helpful within the context of my system. So I think that's an important piece too. But thank you for the question. I love that, and I think having an eye on the research and the data to show that this is a powerful intervention is really important.
Thank you, Dr. Mayberry. Barb wonders, how do we teach clinicians to use versus misuse peer support specialists? And when will it be more okay for professionals, clinicians, to come out with their own lived experience stories?
I think team-based approaches, Barb, are very important here. All of my own work, both as a clinician and as a researcher, has been team-based. And I think it's in the process of those conversations with different members of a multidisciplinary team that we learn how to optimize the contributions of each member of the team and to optimize interactions across members of the team. I think it's very much a social process.
Yeah, I was going to share, stigma runs deep, and that's something that it's not unique to the work of peer support specialists, but in general. So I think that we are making great improvement with reducing stigma, but it's more about, it's more than the work of the peer. I think that stigma is very real to points that we are not even aware that we have internalized stigma, and that prevents people from coming from a lived experience. So I think that the work of the peers, it's so important because, again, like Dr. Mayberry shared, it's that good example of recovery, a positive recovery journey that sets an example of this, that this is actually doable, it's possible, and it leads to more wellness for many other people. It has that triple effect. But I think that we really need to work with stigma across the board, right? Like, as a mental health professional, I have no barriers in disclosing that I've been in therapy myself, not because I want to be a peer support specialist to my colleagues, but because it's as natural as disclosing that I saw my primary care physician 3 weeks ago, right? So I think that we are all responsible in working to reduce stigma.
Thanks, Karen. Really important point.
Yeah, I love that, and I always think about that, how brave it is for these peers to show up every day and talk about their challenges and their mental health experiences, right? Like that's a really they accept their past challenges, they show up, and they try to be the person who they wish they had during their recovery. Really awesome stuff. I think I do, to your point of how do you use and misuse peers, I do think to be honest, this is a little bit of an uphill climb. We are trying to carve out a new discipline and a new profession. It is not, people aren't trying to, abuse the position or that kind of thing. I think there's constant re-education around what a peer is, and we have peers have their own ethics codes and their own training and kind of how that looks like. So I think it's a constant re-education around who they are and what they can do. and a system that can kind of know and understand that and continue to grow. But I think over the past 10 years especially, the discipline has kind of weaved in and out. And wait, are we starting to be more case managers, or how do we really focus on lived experience and how to be the example? And I think there's been this is a new profession that we're just trying to grow. So so thank you for having your eye on that, because I think that can happen. And I think just even by asking the question of, hey, are we using this peer the best way we can, is really meaningful and important. So thanks.
Yeah, Douglas, I wanted to just underscore how my own work with Pittsburgh's African American community really bears out what Karen was saying about combating stigma, and also what Megan was saying about the power of a positive example of recovery. Very, very powerful parts of our armamentarium in the struggle against mental illness and in the promotion of recovery.
Thank you, Dr. Reynolds, and Dr. Mayberry and Dr. Rentis. Dr. Reynolds, you mentioned the word recovery several times, and it's a nice segue into this question, which is, what is the recovery model, and how is it different from alternatives or what was common before?
Megan or Karen, do you want to jump in?
Yeah, I'm happy to speak to that for a moment. So I think the recovery model adds to, and maybe people sometimes just oppose it, but I think it's and to the medical model, right? So we have the medical model where we focus on what's wrong with somebody, what their symptoms are, what their diagnosis is. We prescribe the path forward to healing, and then the patient either complies or does not comply with our treatment plan, and off we go. So I think that this expands the medical model to really focusing on clients' strengths, really being person-centered. So getting on their page and what they value, what's important to them, what they want to see in their treatment, and having a real genuine collaboration in what that treatment will look like. So it's not, what's the matter with you? It's what matters to you, right? It's really trying to understand the person from that level, from a strength-based value perspective. It's a little bit more holistic in that way. So when we say the recovery model, there's kind of a movement within the mental health field that is endorsing this kind of way of working with people and collaborating with treatment. I'm sure there's a million other things I left out with the recovery, but that's a quick 30-second overview.
Megan, thank you. Really beautifully said. Douglas, I don't think I could improve on that one iota.
Karen, do you have any thoughts?
No, so I think that Dr. Mayberry share just kind of like prompted few additional thoughts. I think that the recovery model also takes into account, letting individuals define what success or wellness looks like for them, right? So it's like they are the center of the support, and it's up to me as that individual to decide what's the wellness and how that looks like. Is it connecting with a formal behavioral health professional of, seeing a psychiatrist and, start medication? Or is it reconnecting with my family? Is it starting a new hobby? So it's like giving that power back to that individual for them to define how they define their own wellness. So it steps away from a little bit from that prescriptive model where I am telling you what wellness looks like, but it's a partnership, and we're working in this together so people could actually own their own wellness.
Key word,
you.
Douglas, partnership.
Partnership, collaboration. I love it. Another question was, how has your collaboration with peer support specialists evolved, if at all? All three of you have spoken to that a little bit, but any more thoughts on that?
think I've come to appreciate that there are a number of different functions, Douglas, that peer support specialists can provide. Most fundamentally, perhaps, a lifeline, something that I saw with the group that you and I were involved with last year. But peer support specialists also, as Karen and Megan have said, provide a bridge to the clinical team that may also provide a bridge to other community resources, which I think is also very, very important on the road to recovery.
Dr. Rentis, Dr. Mayberry?
I'm just thinking that for the project that where we have behavioral health specialists and the support of peer support specialists in the community, our relationship has evolved as when we have meetings where we take a deep dive, as you would evolve any other relationship, the more you meet and the more you share experiences and work together toward a common goal, there is greater appreciation into the work of each other. So I think that yes, we have evolved in how we connect with each other, but it's a product of partnerships that are intentionally developed. It's not something that happened by as a side effect of something. It's something that was actually it was intentional. It was an effort, it was intentional, and we put effort. And our partnership with DBSA has been great because being just a true believer that the work of the peers are very helpful on every single level, right? It's not only for the patient, but for us clinicians. So yes, I think that we have evolved as we connect with more peers and we support each other, and it's just deeper appreciation for their role, what they could what they bring to the table, that it's very unique and refreshing.
Douglas, going forward, my hope is that the peer support specialist movement will continue to expand, that we'll see greater integration of peer support specialists within mental health teams. I think this becomes very important from a population perspective because the nation is increasingly diverse with respect to our racial and ethnic group composition. And this is one important area, I think, where peer support specialists can be very helpful in the ways that we reach out, for example, to communities of color, as I've been involved with in Pittsburgh.
Thank you. Dr. Mayberry?
I love that. I won't add too much. I love the focus on community integration. That is something that has my heart. I really try to help support my peers to help folks get involved in the community of their choice and what that looks like. And I think it's a real niche for peer supports too. I think that's really a place where they can be helpful in this recovery process. And it is a limit of most clinicians of taking that next step of taking someone out in the community. So I love that. I also think there's an evolution, at least what I'm hoping for is we're getting peers on advisory boards, on committees. There's a clinical team. I want to peer on that. That they are being more seen as a valued discipline and professional. And I think there's growth in that. And that part's important, and also within different clinics. So they are being expanded not only within mental health, but we now have peers in whole health, which is essentially kind of a wellness program. We have them in pain clinics. We have them in primary care. So we're expanding where peers are, and really folks are seeing the importance of engagement and treatment efficacy with peers, not only in mental health, but even a little bit beyond that. So I think there's an evolution happening from that perspective too.
I think also that it's been really gratifying to watch the peer support specialists themselves grow as a result of serving as peer support specialists. They get a great deal out of the interactions themselves. They themselves grow. Their own recovery journey is, I think, strengthened from giving to other people. And it's a win-win, Douglas.
I thank you all for for your sharing. I know we're over time. I'm going to ask one final quick question of all of you, if I may, which is all of us that are not clinicians, what's one thing that we can do to hopefully increase the likelihood to see more peer support specialists on staff at clinics and healthcare organizations around the country and around the world? What's one thing that you think we can do to help increase that likelihood? Is there anything that comes to mind?
I think going back, Douglas, to our earlier conversation about research, let's continue, all of us, to support research into the impact of peer support specialist program, because I think that data of that kind, and Karen, you're collecting that, and in the Senior Strength Project, will help to support the argument for expanding peer support specialist programs.
Thank you.
Yeah, I would say that, just take every opportunity that you have to speak out the value of the peer support. I think that when we deliver the same message over and over and over and over, at some point, someone's going to say, oh, wait a minute, I just heard the same thing from someone else, right? So I think it just taking advantage of, every single opportunity that you have to talk about the benefits of having peers supporting other peers. That's your opportunity. And if we all that, it does have a snowball effect where people at some point, those people like making decisions are going to start saying, oh, I've been hearing about this. I think perhaps this is the time that I need to listen and do something about it. So just take every opportunity that you have to bring the value of the peers.
And Dr. Mayberry.
Yeah, I don't know. I think I love the all of that stuff, and I try to do that every day in my role. I think for folks that are on the call that are not clinicians or not within system of care, I also think you can ask for it. I think if you go to your doctor or you go to a mental health professional or whatever that looks like and say, hey, do you have anyone who's been through this treatment already? Or it'd be really helpful if I knew how this worked from a consumer perspective or how that works. I think asking for it could be another kind of bottom-up angle to get what you need. If you buy into connecting with somebody who's been there, connecting with someone who's walked down that road would be helpful for your own process. I think you should ask for it, and know that we're working up top to try to lay pave the way. And if the demand's there, hopefully we can meet in the middle and make some really great treatment teams.
Thank you, Dr. Mayberry. I want to say thank you, Barb, for your comment. Nothing about us without us. That's a phrase I love. It's in our peer specialist course. Yes. Audience members, thank you so much for being with us throughout our leadership summit. Thank you for being with us today so very much. Doctors, clinicians, heartfelt thanks personally and professionally for you taking the time to engage and share with all of us today. It is absolute privilege, and we're so grateful for that time and for all that you do. And we look forward to, I look forward to how much we're all going to continue growing forward together.
Great. Thank you so much. Wonderful to see everybody. Thanks for being here.
Be well.
Have a good evening.